So we know that different molecular processes can drive cancerous growth in kidney cancer. And we know that the cardinal event that we have targeted therapeutically in kidney cancer is functional loss of VHL and upregulation of tumor angiogenesis. But in addition to that, we know that VHL, through upregulation of hypoxia-inducible factor, can upregulate a number of downstream protein targets and cellular programs. And some of these can be targeted in parallel to targeting VEGF. So what multi-tyrosine kinase inhibitors do is they block not only the VEGF receptor, which is their main target, but they inhibit various other molecular targets, such as the platelet-derived growth factor receptor, AXL, c-Met, and so forth. So it's really an approach where we try to hit more than one target, recognizing that the cancer most likely on the molecular level is not only driven by one singular pathway. Tyrosine kinase inhibitor therapy in frontline treatment of advanced clear cell kidney cancer tends to be very effective, and we can see RECIST objective response rates in over 30% of our patients for most of the agents we commonly use in our clinic. We know that many of these patients can have extended periods of disease control. However, ultimately, the inevitable consequence of long-term use of these medications is the development of acquired molecular resistance, meaning a patient who goes on TKI therapy, ultimately, even if they have good response, will experience tumor growth on their scans. When we are now starting to learn the molecular underpinnings of why that happens, and we can exploit that in the development of new therapy options, it's generally thought that using combination therapy makes it less likely for a tumor to break through the therapeutic approach and develop acquired resistance. And we are yet to learn whether the combinations that we are starting to use in clinical trials now ultimately will yield longer-term responses or longer-term control, really, of the underlying disease.
The strategies that are being employed and developed in the frontline setting are combining new agents, predominantly the IO class agents, with traditional TKIs. Unfortunately, not all TKIs are combinable in a manner which is safe and effective. And we're seeing that with our staple first-line agents, sunitinib and pazopanib, being difficult with toxicity concerns when one combines them with a variety of PD-1 and PD-L1 inhibitors. We've seen reports at this meeting of a pazopanib combination with pembro, which had excessive hepatotoxicity, for example. So given the fact that we believe that combination strategy, which would involve employing inhibition of VEGF pathway with immuno-oncology approaches, is going to be important, and we have phase 1 data that supports that statement, finding VEGF targeted agents which are more combinable with less toxicity with IO agents is of importance. And right now, from the phase 1 settings, and we've seen these reports at recent meetings, it appears that axitinib or Inlyta is a combinable agent. Lenvatinib also seems to be a combinable agent. And then bevacizumab or Avastin as a combinable agent. And so all three of those VEGF targeted agents are being combined with a variety of different IO agents in the frontline setting. The hope is that one can again combine those at near maximal doses of the single agent to maintain efficacy, and then hopefully provide synergy as we stimulate an immune response with the IO agent, all at the same time not compromising toxicity. The role of sunitinib and pazopanib in the future is uncertain. As data matures from ongoing pivotal studies of combination strategies, the role of single-agent sunitinib and pazopanib become less clear. For instance, if one of the combination strategies shows that it is better than the current gold standard, which is sunitinib, then it will supplant sunitinib as frontline therapy. Whether or not a physician should choose sunitinib or pazopanib in a later line of therapy is uncertain, as there is minimal to no data supporting its use in that setting. Again, as you all are aware, this past year we've seen 3 new agents with strong levels of activity in the second line setting. We don't have data that supports the use of sunitinib and pazopanib in the same manner in that setting.